Hello and welcome back, everybody. Thank you for your questions in the chat. I think this is a new meeting, so I'm not sure if the chat questions are on there. Farouk, did you want to say anything about any of the questions in the chat?
I'm sorry, maybe I'm not seeing. I think I've only seen one or two that I've tried to answer. I don't know why the others are not showing. So the only question I could see here is regarding, let me see, about ozone. I think Ammar has responded, and I've also responded to that. And the other question is about not having dermatoscope in GP. So I've answered that as well. Those are the two I've seen. The third one is from Dr. Akintunde about how the specialties were decided on. I think that would be for you. Otherwise, I can't see any other question.
Okay. No, I think I've got. I can't see that question, but yeah, I can do. As far as the
tabs, I think there's two tabs. There's one for chat and there's one for Q&A. So I think the Q&A
okay.
tab.
Okay. I've been looking at the Q&A. Okay. I'll check the chat and see if I can respond to some of them.
I think if you put your email in the chat and we'll email you we can find out what's how people are accessing it. Right, so if we'll just move on. As far as this,
Cathy, I don't know whether you need to maybe sign in and out. You're a bit, it was a bit broken there for me.
The last few words, sentences, I couldn't hear anything, Cathy.
Right, I'll just quickly move to some stronger Wi-Fi.
Okay, I think it's better now. Can you repeat your last statement? I think you mentioned something about me. That was.
Yes, if you could just pop your email in the chat for people.
Okay.
Just a quick one. I just had a quick look. There's two sections for it. One is for chat. The other one is Q&A. The one that we're using is chat, not Q&A.
All right.
So if you click on the chat one, you'll see the questions.
Okay. Thank you.
Brilliant. Yes, so I think basically if Farouk, you can put your email into both the chat, and the Q&A, then well, into the chat, then people can specifically ask you about those training issues or accessing dermatoscopes and that sort of thing. I think there's somebody with their hand up.
Julia, I've allowed your mic so you can turn on.
Oh, thank you. I was actually just going to type it in the chat. No, I was just going to say there's the questions about dermatoscopy, and that's not a core GP contractual requirement to have access to dermatoscopy, and it's not funded as far as I'm aware. So it is something that, although it may be desirable from the dermatologist end to have pictures, and even if we have dermatoscopes, we often don't have dermatoscopes with cameras, and that would be quite expensive equipment that there isn't funding in our practices to get that. So I don't think it's a reasonable expectation to say all GPs should have that and all GPs should be able to submit a photo with a dermatoscope. And that's certainly something that would need to be resourced if that was going to be required. And speaking as, like I'm an LMC rep, as are others on here, that's the sort of thing that we can't really accept as a sweeping statement for a specialist to say, right, just because we're busy, you need to do all of that in general practice, because we're busy too and we don't have those resources available to us. If it was something that was funded and rolled out as a service for some GPs to do on behalf of other GPs, that would work. But it just does worry me when things like that come out, because that can happen to us from everything, and we're the general fallback for everything, which is what leads to these feelings that picked up in the survey in the beginning. So I don't want to be a negative Nelly, but I just wanted to point that out. Thank you.
No, I think that's absolutely true, and I think that's not what we're saying at all. I think dermatoscopes are, it's the icing on the cake to a certain extent, and it can be helpful. You know, the patient, if you do happen to be able to do that, then that, you know, that will be easier for everybody, but it's certainly not advocating that you could do that. It might be that something, if we can make a case that, you know, there could be more training, or we could have hubs locally where people could go and have dermatoscope pictures taken by trained, you know, healthcare assistants or whatever. That's all possible going forward. But this is really, they're just sort of stating the facts. But I think it is reasonable for us to give, if we're going to get A&G, to provide you know, reasonable photographs. I think that's fair enough. So, and then just the one other chat that was a thing that was in the chat as to which specialities were chosen. We basically chose the specialities that responded to my approaches at the different hospitals. So they were the specialists that were interested in improving their communication with GPs. So we're hoping that you know, other specialities will be interested, and we have found that after 6 months we now have been able to roll it out to 4 more specialities. So that's good. So just going on to start the afternoon. So looking at how we might be able to improve the interface. So there has been quite a lot of work been going on in the past to improve the interface. Probably back the last 3 years, it's been hotting up. There have been joint papers written with the medical colleges, with the Royal College of GPs in the past, and that's 2 of them. And then things hotted up more with the change of government, and you may remember that Wes Streeting put out the red tape challenge, where we were able to give responses as to what we felt was causing excess bureaucracy in the NHS. And then this reported and came up with 10 recommendations. So included in that was working on get it right first time and bridging the gap on the interface. There's now a national group, interface group, which I sit on, and that presents cases of people providing good practice, communicating well in different initiatives around the country. And another initiative as part of the Red Tape Challenge was providing standard templates for discharges and referrals and A&G, and they're all on the Futures website. They're not there for all specialities, but they are being developed, and I'll sort of just show you a couple of those further on. And the other thing that's come out of the Red Tape Challenge, although we did have a group, I think, before pre-existing, is that there is a Northamptonshire System Clinical Interface Group, which again meets monthly, which a few of you are also on that group, along with interested consultants from NGH, KGH, and the NHFT. We have people also from the ICB and LMC sitting on that group. And one of the main things that's come out from that, we'll work on topical issues such as wound care and all the different pathways that are coming out. But one of the main things that has been produced by this group is a document which has been signed by or KGH, NGH and NHFT, which promotes good standards of communication at the interface. So coming out of that fairly shortly, once the full wording has been finalised, we will have these little laminated sheets, A5 sheets, which will be in every outpatient on every ward. And that will remind consultants and secondary care colleagues that they can do fit notes for more than 2 weeks, that they can refer between specialities, that they must give 28 days of medication, these sort of things, if it's required urgently. And we also have a similar one for NHFT, which will get distributed there. And it wouldn't be fair if we didn't have our own one. So the standards that are expected of GPs in stating clearly why we're referring and what we're asking for, providing adequate information for a decision to be made. So that's those will be coming out hopefully in the next couple of months. So just to mention the advice and guidance templates, which are on the Futures website. There's several specialities. Now, these are designed actually as templates for consultants to reply to A&G rather than having to write the same management for the same condition multiple times, which many consultants are just feverishly typing away. This is to help them to produce standard advice. So these are the ones that are available in dermatology, and they have this sort of format, which gives links to various guidelines and standardized treatment pathways. Again, we've got them for urology, and those are the sort of things that are there. So a first line advice for females with recurrent UTIs would be initiating topical estrogen and that sort of thing. So the hierarchy of things that you would try first before referring on, ideally. So that's hopefully where we're going with improving things locally to fit in with what's going on nationally. And this is our team now. David Payne, who's just about to speak to you, he suggested that we should have a photo with all of us together, not in two separate groups. So with the help of AI, we've brought us all together as a team. So I think it's over to you, Ammar and David, if you've managed to sneak out of theatre.
Thank you, Cathy. I think I saw David lurking in the meeting. Let me share my presentation, if that's all right. And actually, I don't know if David wants to say a few words at the beginning, maybe.
Oh yes, I think I think David had a few slides that he wanted to.
That's right.
Share. I'll see if I can find them. Here they are. Is that helpful?
David, I don't know if you can hear us at all, or whether you're trying to talk through these slides, or should I do my bit first if you've not managed to make it through from the theatres? I wonder if he's waiting till 3, Cathy, to join. I think
he possibly is, yeah. Do you want to?
He was in the room. He's literally just left.
Oh.
But should I kick off, if that's all right?
I think you kick off with your presentation. Yeah, that'd be great.
Thanks. Let me just share my presentation. Welcome, everybody. Hope you're having a wonderful afternoon, and I hope I don't bore you to death. I've got the later slots, so you're maybe the postprandial lull that might be kicking in a little bit if everybody's had lunch. Can anybody see my slides yet, or are they still not showing?
No, they're fine.
You can see them, can you? Okay.
Yeah, absolutely.
George, you just pop your hand up. Oh.
Cathy,
Yeah,
can you hear me?
for some reason, I
Yes.
can't seem to see them.
Sorry.
But it's
I've
good
just
that
gone
you
to another computer. Sorry. The other
Are
one's
you there,
working.
David?
I am, yeah. Sorry.
Oh, wonderful. I'll move to your slides then.
Sorry, I've gone onto a second computer, so how posh is that?
I'll come off the sharing then, if that's all right. I'll let David do his bit once he's here in case he has to get away.
We can't hear you, David.
I'm not sure. Hello.
Yes, we can hear you
Yeah, I
now.
can hear you now, David,
Yeah. So thank you for giving me the opportunity to chat this afternoon. Quite an amazing number of people in the meeting. So if there's 253 people here, well, I'm quite honoured. And I'm sorry, it's only going to be a quick overview for 5 minutes. But for you, those who don't know who I am, I'm David Payne. I'm a urologist by background. I've recently taken on the UHN CD role for the directorate. And my remit is to cover not only urology, but breast surgery, gastroenterology and general surgery. I'd like to thank Cathy for giving me the opportunity to be involved with this project. I think it's an amazing bit of work, and I think the potential for this is absolutely enormous. And I think the gift sits with all of us to actually improve the way that we work between primary and secondary care, and I think we all need to get really behind this work. I'd like to thank Ammar as well for taking on the work with urology and coming into the lion's den. I feel a little bit that the tables turned today, so perhaps I'd know a little bit how you feel. Ammar's kind of working with not just urology, but also general surgery. And we've got Georgina coming in to support working with gastro and the breast teams. That's great to see. As Cathy's already alluded, this is not kind of new. There's quite a lot of documents out there. And I must admit, I didn't know Cathy was putting about GIRFT, but GIRFT has been very influential for the stuff that I've been doing with urology over the past few years, and it's they're a good source of reference. So the slide with sound and music is let's start at the very beginning. So I kind of, when I started off chatting to Ammar at the beginning of our journey, this was a kind of a list of all the things that I could think of that we interface regularly with GP practices and GPs. List is not exhaustive. A lot of it is covered within the documents that's stated, but nonetheless, that's kind of been like a working starting point for us. If you can move to the next slide, that would be brilliant. So when we started, the first thing that I kind of did, we took Ammar around the urology team, our 60 team members, to introduce him, because obviously behind any team there's some key members there. So we've got him to see all the consultants, all the admin personnel. He's then had the pleasure of learning all our lovely computer systems, and I think that's been one of the biggest kind of challenges that I think he'll probably acknowledge, is that the computer systems at Kettering Hospital are really not particularly fit for purpose. They're not integrated. And certainly when we reciprocated and I was looking at the computer systems that you have in primary care, you are many years ahead of where we could be. So I think probably one of the first points I'd say is I think we need to kind of get much improved IT systems. The story is not really between Northampton General Hospital and Kettering Hospital. There's a lot of time and money invested currently, and soon to be UHL as well. And I think we really should be kind of putting this support into better systems between primary and secondary care. I think it's really important that we're getting the momentum going, the group's getting bigger. I know that Az and Jane Chambers from Transformation are now on board as well, and it's really good to see them in the fray as well. I think one of the things that we kind of appreciated going through the work is we also need to get county-wide approval for any work that we do. We can't just do it as Kettering Hospital at North of County. We need to kind of get the whole of the county involved. Now, it's quite difficult, as you appreciate, when you're in perhaps just one GP practice to make any changes, let alone when you're in a hospital, let alone 2 hospitals. So the challenges are going to be quite great. the slide that I put up is probably the main areas that me and Ammar have kind of been looking at, and we spent many a morning and a coffee chatting through the various things that we get up to in primary secondary care, and quite a few biscuits have been provided. So thanks again, Ammar. We've started off with doing quite a lot of work with the choose and book, and just from a perspective at Kettering, we have a really big backlog of patients, and it seems to be more specific for certain specialities. I think gastroenterology seems to be a really hit team at the moment, and I know until recently they had 700 patients sat on this RAS referral system, which is where patients don't actually get allocated to appointments. They just basically sit on the system waiting for a triage. This is also quite challenging because we're getting a lot of pressure for job planning within the hospitals, and 12 PAs is the magic cutoff. And so to actually allocate time for going through things like the choosing booking is a continual difficulty we get from the consultant saying they just don't have the time to go through the referrals, which we're trying to work through. I think the other big word that we kind of kept coming across was consistency. And when you're triaging, it doesn't mean tick, yes, it's a clinic appointment. It does mean spending quite a lot of time going through the referrals, looking at the imaging, looking at the previous investigations to try and make a meaningful outcome to the patients. One little thing is just urgent referrals don't mean urgent. And if you actually do the audits on this, we don't see a massive difference between patients which are referred as routine versus those that are referred as urgent. And I can completely appreciate it from GPs when there's no kind of intermediary apart from sending these patients through A&E. We're doing quite a bit of work with SDEC to try and improve the flow of patients, but we're not signed up to all specialities. And we're also trying to set up kind of hot clinics, so you've got this kind of halfway house. But you know, we do see patients coming probably through a 2-week wait, referrals through frustration. There's no other opportunities for these patients to be referred through. Just moving on for a couple of comments about advice and guidance, and it was a lovely audit, Farouk, that you've done there for the advice and guidance, and I just wonder whether we should be replicating that to other specialities. We have done some audits, and I think Ammar, you might be touching on some of those about what the outcomes from those are, but I think it certainly wouldn't hurt to update those and modernize them. Again, I think consistency would be another thing that I would say about the A&G referrals and the way that they're handled. We do have issues again with colleagues turning them around in a timely process. But equally, we are seeing massive increases in numbers of A&G referrals, which does cause quite a bit of a headache for clinicians in the hospital. If you could just move to the last slide, and then you'll be pleased to hear that I've nearly finished. So I think, having spent a number of weeks with Ammar, I think there is 2 elements that we're looking at really, and I think we need to look at system-wide change, and I think that's going to be, you know, need a real movement to be able to provide such a platform. And I think we also need to look bottom up. I think we need to look at flow of patients, and again, I think Farouk, you touched on it with the pathways. We need to be looking at those pathways. We need to be working together as one, so how we can facilitate smoother pathways. And I think it was interesting when we got to meet up with Az and Jane Chambers that they kind of discovered the GP portal, and they're pushing this as a good medium. And I think it makes a lot of sense. I think if we can use that as an interface tool and we can populate that with meaningful information, and we could also consider directories in there so we can easily chat to each other, which would be really nice, rather than you trying to find out whether I'm on call, whether I'm in theatre, and me likewise if I'm trying to get through and go through several different options to find that someone's not there. And I think the other thing that I think you suggested, Ammar, which is a really good idea, is having these kind of mental health networks, but within the primary and secondary care, where we could have liaisons between specialities, so somebody within each speciality who directly communicates with somebody within primary care and reciprocates. And again, Farouk was just mentioning about modernising and updating on information. Well, that would be a perfect example of how that could work well. So thank you very much for giving me the chance to chat. I'm really invested in this project. I think it's got a lot of great potential, and I'll hand you over to Ammar.
Thank you, David. Thanks for that, and thanks for the general support. And I think I just want to say, I think, without sort of Cathy, David, and others, I don't think this project would have taken off. So I'm really grateful for them to bring this to our community of GPs within Northamptonshire. But let me get my presentation on the screen 1 second. Hopefully you can see my slides. Is it possible to get a thumbs up from anybody, or just a shout? Yep, thanks. Thanks, David. Great. Yes, essentially my role started in the autumn last year. I was, my practice manager saw the advert for this role and obviously thought I wasn't doing enough. So she said, Ammar, you might be good at this, go ahead and apply. So I did that, and I ended up working for my sins on a Tuesday morning in the urology department. But I've enjoyed it actually thoroughly, and I'll tell you a little bit more as I go through the presentation why. So a bit of background to myself. So my name is Ammar Ghouri. I'm a GP partner at Lakeside in Corby. So that's where my bread and butter role is, and my day job here is for the latter part of the week. But I also have a role on the LMC as a rep for our practice, as well as the locality lead for Corby and Oundle, although I might be changing a little bit with the neighbourhoods. But nonetheless, I think those roles provide a synergy to some extent in terms of intelligence gathering, at least from all practices, my own partners that come and find me when things are not going right, but also from the locality gathering that intelligence, and also along with the LMC about what's happening and trying to keep a finger on the pulse about the challenges that people are having with interface, both with secondary care, but also from a secondary care point of view with primary care as well, like getting it right really first time. So this is really where the objectives for this role came about from. And when I was speaking to Cathy at the beginning, I think it was herself and Mike that interviewed me, we were really discussing what the role's objectives would be. And I think I divided them up into 3 sections, and Cathy's already highlighted them really, which was around communication. Such a big thing really in terms of getting it right. I think this is the bane of most of our lives, and I think it's not any different speaking to consultants in secondary care, or secretaries in secondary care, or even the waiting list officers. Communication is the biggest thing really. I think that lets us down, and that makes it quite frustrating for us. Not understanding how people are navigating the system, or what can be done by specialties, what can be done by primary care, and what's the art of possible. So alongside that, looking at pathways that David's already alluded to, one of the things was like trying to optimize the utilization really of the clinics within the hospital. Now that is very much an internal thing, and I didn't want to get sort of too bogged down with that, but I think it's important to think that if we can optimize that with the input from general practice, from the referrals that we're sending in, then that means that we can reduce the waiting times to hopefully get patients that are appropriate for their clinics be seen in a timely fashion and not having to wait months and months at a time. We looked at sort of advice and guidance versus choosing book versus 2-week waits, and sort of the different challenges with either all of those. So, for example, to give you an idea, I think David was alluding to it, the way that advice and guidance is handled by many of the specialties, it can feel a bit archaic. Like what we think is sending off an electronic request is actually how it's printed off at the other end, or how a consultant may review it whilst they're on call, for example, and with very little information that we get back sometimes, it can be a bit frustrating. I think for both sides, with not getting a lot of back and forth really, and for the patient it feels like they're just constantly in that loop really. Cathy's already touched on getting it right first time, so I won't dwell on it too much, but just to say, I think there is something there for us as GPs to really pick up on, and to think about how we can access that. Because to be honest, when I see a patient, I want to just solve the situation there and then. I want to be, not waiting for my secretary to send a response to the consultants, then wait for them to respond, usually weeks or day, later, and then therefore having to contact the patient again. If I have access to the answer straight away, or if I know what they're going to say, and that's sort of been agreed really by them, then I think that makes it a lot easier for me to then turn to the patient and say, this is what the management of your recurrent UTI should look like, or these renal cysts are not to worry about, etc. And the last strand was around educational and engagement activities, and this is why we're here today, really, to try and bring individuals out from secondary care into the primary care world and to get to know them, really, because I think that's been a real shame, really, in the last decade or so, that we've lost that connection with our secondary care colleagues who are equally brilliant, just like us in primary care. We just don't know their names, or we don't know where they work, what specialty they work in terms of what special interest they have in that specialty, and then how we can get in touch with them. So I'm hoping that we can maybe use some of the ideas we're discussing today to break those barriers down. And these objectives really came on the back of a survey that was done by the Training Hub, which looked at the retention of general practitioners within the county. And it wouldn't be a surprise, really, to many of you to recognise that the major signs or major comments, really, and feedback back from job satisfaction were around the fact that there's a lot of workload in primary care. Well, I know it, you know it, and I think hopefully the government is hoping to do something about it. That's a national issue, and certainly within the local area, what we can control is obviously how we interface with each other to try to maybe reduce some of that inappropriate secondary care workload that some of you have highlighted in that survey, and also around the poor communication. So I think when I delved more into it, I recognized that actually, this is going to be helping individuals to think about having longevity in their careers if we can make things more equitable, more fair, and just more easier for our patients, really. Because I think that's what frustrates us a lot of the time, when we have long waits, we don't get advice in a timely fashion, or we can't communicate with the people that we know can give us the answer. So just an example of what I might find, for example, if I turn up on a Tuesday morning from the waiting list officers, trying to reach out to me, say, this is an example that I hired from them regarding a referral that was sent to the urology team via ERS, but actually they couldn't access the information, and it was a lot further down the line. Actually, it was nearly like 2 months down the line, and David was triaging these, and basically he recognised actually the patient needed to be upgraded, really, because we shouldn't be waiting ages and ages to see this gentleman, and he would do that. So I am grateful for the colleagues, because we sometimes send our referrals into the ether and we sort of don't know what's happening, really. But I'm glad that at the other end we've got humans that are actually looking at this and are actually taking the time to analyse it and escalate it where it's required, really. But certainly these are the type of queries that I was having to answer, and this was a good learning experience for me, because I was speaking to a lot of the administrators actually within my own practice, finding out what do the secretaries get back as feedback when they submit a referral, when they get a rejection, and likewise at the other end with the secretaries liaising in secondary care, because they're a fountain of knowledge that we haven't really accessed or tapped, really, and they can really help to make our lives easier. It's not all about us doing more as GPs or the consultants doing more. It's really a bit about working a bit smarter, I think. So I'll just move on to the next slide. And so this was an audit that was done looking at the triaging of choose and book referrals, really, within urology. Now, whilst the sample size might be small, I think what it highlighted was actually a number of them could be what would decline actually nearly a quarter, on the basis that actually they didn't need to be seen by urology. They may have been more appropriate to go to, I don't know, urogynae, for example, or they may have been more appropriate for the renal team or for the cancer team, etc. So that helps to, that adequate or good triage really helps to open up capacity and valuable space by using the correct pathways. And if we're on the other side using the correct pathways, it means our patients experience less delays, I think. So I think this is some of the things that I've recognised, really, from the other side, looking at it and the challenges that they have. And I think clearly, they are doing a lot of work in the background in terms of upgrading patients where they're required. So, for example, if they get, uroteric stones that need, management more urgently, they're happy to do that. But I think one of the things that for me from the triage, from the audit, was really highlighting how we can improve the throughput through their clinics. So as GPs, if we are requesting, some more information, whether it be around, I don't know, the international prostate symptoms checker, basically, the questionnaire, or if we're using the flow volume charts, or we're getting maybe an MSU or a HbA1c done. It really helps to streamline their clinics to make sure that the patients coming in can be truly seen in the one-stop clinics really, and discharged after their investigations, etc., rather than having to come back for continuous follow-ups, which obviously clogs up the system. And the overall benefit to the system for us as clinicians is that if we can bring down the amount of people going into the system, or make sure that appropriate people are going into the system, they will get seen quicker, and they will get the care that they need in the right setting really. So the key themes that came to me, no surprise, was around communication. I think it needs to improve both ways. I've seen examples of excellent communication from general practitioners, with nice, thorough letters, and I've also seen, examples of poor communication. And likewise, I've seen that from, secondary care's point of view as well. My colleagues in the partnership over here, will bring me letters and show me this and say, this is Ammar, this is not right, this is not on, and I can see it from their point of view as well. I think an understanding of the systems and how they work is important, and it will not surprise you that many people in secondary care don't have the foggiest about our systems, about how they work, about the access to information that we have, in terms of current medications, previous medical history, letters, etc., which they don't have really at this stage, and that needs to be improved. That's more of a bigger long-term plan that really we won't be able to influence as individuals over here. But there are some areas that we can. So pathways, certainly I think we can help to maybe support the referrals by making sure that things are done, like Farouk was saying, in a structure and a format that they appreciate at the urology end, and other specialties. And it may well be that we need to do some basic investigations. Doesn't necessarily mean that we have to actually physically do them in the room or physically request an imaging investigation. It may well be that there is a box on, say, eyes, for example, like urology investigations that includes using these HbA1c and FBC, which is done at your diagnostic or something along those lines. That way, not putting too much demand on your actual resources in the practice. But it helps to maybe smooth the process along, making sure that they're not waiting after the waiting list officer takes that referral to the consultant, who then says, oh, I need X, Y, Z. Then that goes back to the patient, and the patient has to get those investigations down at Kettering, and then it's a lot of toing and froing for poor old Doris, for example. And the last thing I think I recognised was technology, really, or the lack of use of technology effectively, really, within probably the secondary care setting, and how we can maybe use it within primary care, whether it be through portals or whether it be through referral decision aids, for example, that can help us to make sure that we are sending the right patients to those clinics, for example, where they actually add value to the consultation that they experience in secondary care. I'm just about halfway through. So, yes, we need to talk more to each other, really, is what I came to the conclusion. And speaking to colleagues further away, I think through using Cathy's connections nationally, I came across neighbouring areas that are trying to also address the same barriers, really. So this was a slide I've stolen from a presentation from Nottingham, really. And what they highlighted was how the impact of GPs not being able to get in touch with secondary care has basically a ripple effect in terms of causing frustration, causing delays to the patient journey. And they looked at the problem, how they could solve the urgent problem of communication between Nottingham University hospitals and the general practice setting. So not much different to us, I would stress. And they conducted a pilot of a WhatsApp group over there, where they had a small group initially in November 23 of GPs alongside individuals from the secondary care trust, the deputy medical director, they had an operations lead, a digital lead, and the primary secondary care interface doctors involved, with trying to address issues of, say, let's say we're trying to get hold of the nurse on call for a surgical admission, nobody's answering the phone, maybe they're stuck in an emergency, maybe they're off sick, those sort of things we're just struggling with. How could we get a satisfactory resolution within a timely fashion? And this group initially started off in that guise, but then it's expanded, as you can see on the slide, to up to 71 members as of March this year. So it's had quite a positive influence. It's not really a group about moaning or chat basically, or idle chat. It's more sort of for action really. So raising issues that need addressing within a short period of time really. And I think this is really where it's been shown to be quite beneficial really from that point of view. They responded to most of the queries within hours really. And if you look at their thematic sort of analysis, whilst it's still ongoing, the initial observation from them was that most of them were linked to human factors, lo and behold, and they were addressing them quite quickly. So then that way they could get people or doctors, for example, to speak to the surgical team on call, or to the MD, or if it's an IT problem, they could get a response out and a message out a lot quicker. So this is something that I did propose to David to consider, and I think this is something that he's very keen on, trying to improve communication. But this is not just the one way of doing it. There's lots of different ways of doing it, and certainly David alluded to the idea of what I saw back in November in one of the primary care bulletins, which was one of these slides that for Corby and Kettering, and for other localities you had a similar one, which was really a bit of a crib sheet for contact details for individuals working in these areas and whose practices they covered and how we could get in touch with them, and names and emails. So this was quite helpful really, and I put it out to you guys really, whether you think it would be helpful to have something equivalent in urology really, with people's details on there, so you actually know these individuals cover your area in the north, for example. David over here maybe from Kettering, or Tom from Northampton, for example, and you can reach out to them, or for example, the nurse practitioners, for example, if you've got a prostate cancer patient, your oncology nurse, for example. So I think there is something to be said about having that directory, having that communication, of us being able to just get on and speak to individuals rather than actually just sit back and think that, yes, okay, we'll send an advice and guidance off, we make it a response, and then we're not quite happy with the response. But actually, I think most of my conversations in the past certainly have happened are direct ones really with the clinicians involved, because clinicians do want to solve problems, and they do work together a bit better, I find, when the patients are involved and at the centre of it, and if we're having conversations that are framed sort of in a respectful way and in a friendly manner. So this portion of the presentation really, I was hoping, along with what David said at the beginning, really, to use it as a jumping off point for us to really think about not just the challenges in secondary care and in primary care, but how we can address them. And really, David is here, he holds multiple hats across multiple sites for multiple specialties. And I wanted to give the opportunity to the audience, to yourselves really, to ask questions of both of us and Cathy really, of what your frustrations are. What do you think would work for you? Do you think a WhatsApp group is a good idea? Do you think having a directory? Do you think having access to somebody in your locality who maybe wants to liaise with the urology teams on a regular basis is going to be a good idea, practical wise, etc., etc. So I'm hoping that there are some questions, or some people want to put their hands up and hopefully maybe share their thoughts really over here. David, I don't know if you want to have any comments about what I've just presented. I know you've seen it before, but in case you've got any thoughts.
No, I think that's a very good review of what we've been up to, Ammar, and I think completely right. We've been on this journey for a few months, but it's quite big and vast, and it's not just urology. I can certainly looking at, and each speciality has its unique nuances. I mean, what we've been doing is very different to, I think, what dermatology has been doing. It's a kind of different problem, and I think the answers are there to be provided by everybody. And what do people want? I think the survey was very clear about retention of GPs. That there is difficulties between primary and secondary care. So we can moan about these things, or we can try and address it. And how do we address them? How do we make things better? How can we just pick up the phone? How can we communicate those things without, the difficulties that we experience on a day-to-day basis?
And I can see some colleagues are putting in some, comments about how useful Consultant Connect was really from a primary care point of view of getting in touch. And I don't think Kieran's the only one really to feel a bit sad when it went away really, because I think it was helpful for primary care to try and get through sometimes to the right individuals, but I can imagine it probably wasn't convenient for maybe some specialties, particularly if you're not having dedicated time for those things. But certainly, yes, I mean, I'm happy to use any or suggest any sort of modality of communication really that gets it done really, is effective really at delivering what we want it to do, which is to have a conversation really with ideally a human being and ideally somebody who can help us really to resolve an issue, to avoid patients being taken from pillar to post really of trying to navigate it themselves, because it is a bit of a challenge. Certainly I know picking up Julia's point earlier, and I hope she won't mind, I sit on the LMC with her, but I think she raises a good point. It's absolutely right, there is no request or requirement for us to do dermatology or dermatoscopy pictures, but actually we've got to try to solve the problem of how we get our patients seen in a timely fashion. And I think, like I said at the beginning, I'm one for solutions that don't involve us having to do any more of the heavy lifting, because we're already at breaking point. But like some of you have suggested in the chat, regarding, like, say, HCAs being brought in to do dermatoscopy photos, for example, or as a neighbourhood we think about that, or maybe through our provider forums that we're hopefully looking to stand up, we can try to maybe use some of the systems or the resources that we have to develop these things. And I think it doesn't necessarily mean that we have to take the photos or we have to vet them, but at least if we can get working together, communicating, rather than thinking it's us versus them, I think that would really make a big difference to how everybody perceives us really, and how we can improve the system overall for our patients at the end of the day. Sorry, David, were you going to say something, I think?
No, there's a couple of questions, I think, in the chat. About using Talk Connect, and I think
that's a good question. I mean, do you think, realistically, with the urology team and how busy they are, and obviously, you have sickness and you have, your on-calls and everything else, do you think it's practical for them to manage these consultant connect sort of interactions really, or do you think, an email one, which is maybe a little bit asynchronous, but certainly asynchronous form of communication, but certainly allows time maybe for people to get back to you rather than on the hop and give better advice?
There's so many different ways of communicating now, isn't there? And there's two kind of types of communication in essence. There's those where you need a direct response very quickly or fairly urgently. And there's questions that are perhaps not as direct. And I suppose people are going to turn around and say, well, that's what advice and guidance partly provides. But I come back to, and I think when you've looked at the advice and guidance and the way we do it at Kettering, I think you'd probably say you were quite shocked, Ammar. We've got pieces of paper flying around with scribbles on. That then gets kind of, responded back to GPs. Then there's a response back from the GP. You cannot see the last A&G from the GP unless you scan it onto the RTT drive. And then if it has been scanned in, you've got a fighting chance to know what the whole story's been. And sometimes it hasn't been responded by you. So our systems are really not fit for purpose. I think the choose and book is another good, the way that the referrals come in to actually get to where you want to be. You've got to filter. You've got lots of clicks before you get there. When you get onto the page for the patient, there's like 3 different files that you've got to click on and see what's in each of those files. And then you hit jackpot and you can actually see the referral. And then, bingo, if you've got the information you need from the referral, it's really frustrating. So, surely in this day and age, with all the kind of, media that, we've got, there are better ways that we can be doing those things. Some of those, will be a substantial outlay, but, things like the WhatsApp group that Nottingham did, they're in existence. And I think it's, we need to be creative. We need to think about how we're going to do these things. And, it's great to have this opportunity to speak today, to try and get people interested and start putting suggestions forward. How would it work for everyone? Coming back to your very first question, you could have an email, for gastro, and people send it to that, and then you answer the, someone who's a consultant of the week would answer those as part of the on-call. There's multiple different ways that this can be done. So yeah, I'm equally interested in what other people's thoughts are from a GP perspective.
So I think, I think Neil's over here put in a few comments. I think certainly about the challenges, maybe discussing with on the day surgical teams and requiring admission, for example. Certainly requests generated by secondary care that are then having to be actioned by primary care. And hopefully the new systems regarding requesting tests will maybe help to reduce that, I hope, and that sort of naughtiness really around, people requesting investigations in other people's names, because it does create a lot of paperwork and hassle for everybody down the road, really. And sometimes this is done inadvertently without anybody actually knowing about it, who's doing it. Yeah, I think, yes, you're right, Neil. I think certainly, requesting things that actually don't need to be done because they're actually been done by somebody else. So better communication in the letters, in the formatting will definitely help.
I think just on point 3 there, to Neil, I think that's a very clear example where secondary care should be referring that patient to cardiology. I think that's very clear pathway. So I would suggest that if there was someone who picked up a cardiological issue in the hospital, it would be for that team to refer it to cardiology.
Absolutely. I mean, I've multiple times scratched my head with David about, responses that I've had from other specialties back to me about saying, please refer here. I refer them there, and that specialty comes back to me saying that's not appropriate. So there's a lot of inertia even between the specialties in terms of understanding, what is the art of possible, what they can actually do, what is their remit, what are they commissioned for. And I think this is where the idea of a portal really came about from, that actually what we need is a repository where we can go to and access information in a digestible fashion. So not reams and reams of Wikipedia, this and that. I think I would be wanting the information to be snappy, to be short, to be concise to what we need. So, for example, I don't really want to know everything about, benign prostatic hyperplasia, but I do want to know what you do after, tamsulosin, after finasteride, etc. What would the consultant do? When would they get concerned, etc. And I think if I could find that information, I wouldn't bother with advice and guidance. I would want to give the answer straight away to the patient and say, this is what we're going to do next. But I know everybody has, different thresholds, different experiences. But I think it's a good jumping off point. And likewise, I think if we bring in, that level of detail that other specialties can also access. So if gastro can find out what urology can do and what urology can find out what breast can do, it's just helpful, I think, for them to have access. They may not have any crossover or have any interaction, but if they know and they can see what they're doing and how they're reducing maybe their demand, I think that will get them to think in a different direction, hopefully.
Yeah, definitely.
Yeah, I mean, I think, Julie, you're absolutely right. I think this is probably my hesitation to sort of push that really in terms of a WhatsApp group, certainly, with patient confidentiality and other aspects, of maybe the way people may communicate on there as well. But I think there's something to be said about maybe how we can bridge some of those barriers. Maybe we've got to start somewhere. So maybe that, that mental health sort of template of communicating that way allows them some control over how they get those messages.
Ammar, just if you could just put to the group, what would they feel about a portal as it's kind of like an interface hub? It's something that Cornwall have done very well. It's something that Az and Jane have kind of jumped on. They want to populate it with specialities and specific pathways within specialities. But I think, again, it's a place where you can contact people. And I just think if it had a critical mass, I think it's a good idea. But equally, I would be interested. People might go, actually, David, I don't think I'd be using that at all. But I'd be interested to hear what thoughts are generally from the audience.
Certainly, yeah. I mean, I already use many resources, and sometimes, unfortunately, we don't have them in Northamptonshire. I mean, I think it's only fair to say, I think when you look at our sort of portal at the minute, it's got a lot of pharmacist probably heavy stuff in there. It's heavy from a prescribing point of view, but from a clinical point of view, it doesn't really solve my queries, and to navigate it is a bit of a nightmare as well. So I would probably want to see something a bit more slicker, a bit more with a better user interface, and something that actually gets my question answered. Happy to hear from others actually in the audience if they want to pop their comments in, whether they would use a portal, whether they would find that helpful. I think a lot of us would love to have advice on things like, for example, I was talking to colleagues about renal cysts, incidental findings that we get on reports on ultrasound. Some of us are not sure what to do with them, whether they're significant, whether they're not. There is guidance out there, but maybe that link to that guidance is not attached at the bottom of, say, that radiology report to help us to get somewhere where we can then interpret that guidance and read it. We're all clever enough to read and interpret things, but we just need to know maybe where to find that reliable information. So I think you've got a few thumbs up there, David, in terms of people sort of saying that a portal would be helpful. It's got to be contemporaneous. It's got to be kept up to date, which is the challenge. And hopefully, if we as GPs can be involved in the pathways, developing them with yourselves, I think we'll get to that middle ground where people find what is acceptable and what's not.
Yeah, there's some interesting stuff coming through on the chat, which is really, really good. Like to kind of see some healthy debate and challenge. And I think there is some things in there which, like after a single DNA, that, as far as I'm aware, it shouldn't be happening after just a single DNA. But again, these questions, it'd be great to be able to have the answers, wouldn't it? And these regular interface groups, maybe, where people do have such questions. So it's great to hear people getting these messages on there.
Absolutely, and I think that's the key thing. I think we're hearing quite a lot of enthusiasm for people wanting to work together and maybe coming up with some solutions, and also highlighting some problems that we maybe have in the system that we are aware of. We've got the LMC, obviously, they have their own primary and secondary care interface group, so we don't want to duplicate things too much, but we do want to make sure that we are getting the right people in the room to help us figure out a solution, really. I think you're right. I definitely don't want to create another portal, Julie. I think I want to use the existing one that we've got and maybe make it better, really. I think that's what myself, Jane, I think we're all trying to work towards, and I think David and Cathy would love to see as well. Coming back to our last speaker, really, so this probably leads me in nicely, hopefully, to them, is I'll just bring my second last slide up, actually, is so we've been working with Mr. Nafi, who's one of the consultant urologists in the department at Kettering, and really I've invited him along today to give us a bit of a flavour of how AI can maybe help us. Now, I don't think AI is going to come and see our patients for us and give us the answers to everything, but certainly it may help us a little bit with both sides in terms of getting responsive answers to our questions that we may submit through advice and guidance, but also consistency with those responses, if it can be taught to sort of work within parameters. And that's really why I want to bring Shady in if he's on. I think I saw him log in, actually, and maybe he might be able to give us a demonstration of some of the tools that they're implementing or starting to implement. Over to you, Shady. I'll unshare.
Thank you very much, Ammar. Thank you for the introduction. Hi, everybody. My name is Shady Nafi. I'm one of the urology consultants in Kettering Hospital, and I've been invited by Ammar to give you a bit of as they said, a flavor of what the future could be looking like. And interestingly enough, earlier today, I was in a meeting on the level of NHS England, as this is like hot off the press. There is a project that has been in the background being developed by NHS England called Demand Center, and this is a piece of software that will be operating on top of ERS that is aiming to regulate and facilitate the communication between primary care and secondary care. So it will be like a unified portal between GPs and hospitals, so that the referral process will be standardized and streamlined. Obviously, there will be a bit of customization between different trusts and different regions to adapt to the local pathways and local guidelines and local facilities and caliber of each department and service. But I believe that it will be released in Northamptonshire for trial or for piloting in June this year. So keep your eyes open for it. Now, Ammar was talking about AI. So yeah, AI is a very hot topic these days, isn't it? I mean, all of us hear about AI everywhere, ChatGPT, Gemini, all that hype happening. But the reality is AI is not magic. AI at its best could be utilized as a helping tool. It will never replace the bedside manner. It will never replace the communication between the doctor, the human-to-human communication between the doctor and the patient. But it will evidently be utilized as a helping tool that could accelerate our performance, could make us more consistent and more efficient. So I've been working on a project whereby we like streamline or try to augment our referral pathways using AI, but bear in mind what you're going to see is just like a prototype that is locally developed. It's not something national, and it's not up to the standard of something very big like the demand center, which is NHS backed up. This is locally developed, to be honest, by myself. So basically, an AI triage will be looking something like that. It will be, imagine it will be a portal, because this could be plugged into the digital demand center. It will be a portal whereby the clinicians receive the referral from the GP, and then the AI does what is called natural language processing and semantic analysis. And through these two processes, it can extract relevant clinical data, and then compare the relevant clinical data from the letter and compare it to the local guidelines and facilities and the services that is run by the department. Then it will reply to you instantly with a professional drafted letter, whether the referral is accepted because it fulfills all the needed criteria, or whether it is rejected because it does not fit the criteria, or whether there is any kind of advice for steps to do or investigations to fulfill before resubmitting. So allow me to just give you a sneak peek of the portal. I'll share the screen. You should be able to see it. So this is the shape of the portal, and let's test drive it together. So what I will do is just copy a demo letter and paste it in. So imagine that this is your letter, and basically saying, I will be grateful for your urgent assessment for this 68-year-old gentleman under the 2-week wait pathway, presented 3 days ago with single episode of frank hematuria, blood was bright red, no clots, no fever, past medical history, on examination, blah, 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 investigations, and I will hit process. So what is happening now is the AI model is reading the letter, breaking it into atomic clinical facts, and then trying to make sense of it, and then comparing it to the well-established pathways, and see if this kind of referral is fitting into one of the pathways. Ideally, we are expecting it to fit it in the hematuria 2-week wait pathway, and then it should reply with a letter of acceptance. I hope it comes back with a reply. And okay, so it says here, thank you for your referral regarding the above patient. We've reviewed the clinical information, and pleased to confirm acceptance of this referral under a 2-week wait pathway, visible hematuria. The hospital investigations will include CT. It will tell you even what will happen, what will the hospital will do, include a CT urogram and a flexible cystoscopy. Okay, if we try it with another kind of letter, which might be a little bit more deficient. This is an example to a deficient letter, so I'll just refresh the page and paste the letter. It says, could you see 62-year-old gentleman in clinic with urinary symptoms, complaining of getting up at night 3 to 4 times. He has to wait to get going. This has been worsening over 6 months. He's otherwise fit and well. So this is intentionally missing some of the information that would be or considered essential for such a kind of referral. So hopefully it will make sense of it, and then give you an advice that this is is a deficient referral, and we need 1, 2, 3, 4 from you before we can accept. Now you might ask, oh, okay, are these rules hard coded?
It's a bit blurry, Shady. I don't know if that's the case for others as well, but it's gone a bit blurry, so I don't think people can see the actual output.
Really? Okay. Can you see anything at all, or is that better?
It's still a little bit blurry for me.
Can I make a suggestion? Turn your camera off.
Yeah.
That sometimes helps. It looks like a bandwidth problem.
Okay. I'll turn my camera off. Yeah. Is that better? Is that better?
It's still maybe a bit blurry. So I think this sort of highlights maybe the IT issues that we have.
Well, I can read the text for you anyway. So basically,
okay,
as we said, we did, and we sent a referral letter, deficient referral letter, intentionally, so to see the response of our AI model. And it says, thank you for referral regarding the above patient. We have reviewed, and the patient's symptoms are consistent with LUTS, and we provisionally accepting the referral. Well, it's very generous here. It says, however, before we can proceed to book the outpatient appointment, we require completion of some baseline investigations like urine analysis, PSA test. You get the idea. The whole idea is what we do is talking back to what we were discussing with David Ammar. We should agree together as a regional group or a regional body about the guidelines that we are going to follow for each pathway. What are the acceptance criteria? What is the GP responsibilities? What are the hospital responsibilities? Once we agree on that, we can easily feed it into an AI model like that, and then it will act accordingly. So any new GP to the area, or somebody who is not really aware or up to date of the guidelines, they just submit through the portal. AI will pick it up, read it, and it will revise the criteria for acceptance and refusal, and then draft accordingly. Now, to put things in perspective, from our side as hospitals, I think this is very useful as well, because ideally, let me give you the other side of the coin. This is what happens, or this flow chart in front of you. Can you see the flow chart, Ammar?
Yes, I can see it. Yes, it went a bit blurry, but cleared up, and now it's gone a bit blurry again.
Yeah.
So I think it's a bandwidth issue. Sorry.
Yeah, so basically this is what happens in the hospital once you send us a referral. I'm talking specifically about the urology department. This is a process map of what actually happens today when you send us a referral. So ideally you submit your referral through the ERS. The ERS, we have a waiting list officer team who check the ERS daily. These people pick up the referrals, and they for some reason, they just book the appointment even before we, as consultants body, triage the referral. So and this is a defect in our system. So basically, the patient receives an appointment straight away. I think what we are aiming here is to beat the deadlines and the RTT clocks. So the point is, get sent to the patient straight away. And then they assign the referral to a consultant, usually the consultant on the day. They fill the paper forms, which takes about 10 minutes each, around 12 hours per week of work. Prepare the paper package, then chase the consultant for a triage session, which usually takes 3 to 7 days. And then once they pin down the consultant to do the triage with him or her, we sit in the triage session. Each patient takes about 15 minutes of processing time, reading your referral, reviewing the investigations, and reaching a decision. And then there are only 3 decisions from here. Either we accept the referral straight away because it's fulfilling all the criteria, or we reject it because it's inappropriate and does not fit any of our pathways at all, or we start booking the patient for more tests and investigations. In the meantime, the patient is getting, in the background, the patient is getting their appointment. Unfortunately, if the referral is rejected, then they might get a cancellation, which annoys the patients a lot, because they imagine that we think we're not sympathetic enough, and we think that they're not worth our care, because we gave them an appointment and took it away back from them. So it causes some complaints and some friction as well. On the other hand, if we adopt the AI kind of vision, or if we put a layer of AI on our system, it will be a little bit more, not a little bit more, it actually is going to be a lot more faster and a lot more consistent, because the AI will go by the rules that we agree on from the beginning. So again, touching back on Ammar and David's point, once there is a general consensus or agreement about what are the acceptance criteria, what are the GP responsibilities in this context, what is the hospital responsibilities in this context, what is the hospital is going to supply for the patient or do for the patient, then we can easily streamline the whole process. So if I'll take you very quickly through the AI-powered kind of triage system. So once you submit the referral through the ERS, the ERS hands it over to the AI model, which will extract the clinical information via the natural language processing process that we talked about. It pulls also, it will be connected to our EPR, so it will pull the investigations. It compares the referral against the local guidelines, local pathways, and even NICE and BAUS criteria. And then it will make up its mind and generate a summary and a triage suggestion. Now, if it is confident and the picture is very, very clear, it will pass it to the consultant straight away in the same portal. And once the consultant mission here is to review the referral, review the AI triage. If he agrees, if he or she agrees, then they click one button to approve or decline. And after the approval, then the patient will be sent an appointment. So in this business model or in this workflow, we don't need to send the patient the appointment prematurely, because AI will be faster to process and the consultant should subsequently be faster to process. So obviously all these are still very premature work. They are just mainly concepts and local development in the region. I believe that UHN, Kettering and Northampton together are going to adopt or incubate the NHS project of digital or what do you call it, Demand Center 2.0 is going to go live. It does not have AI capabilities yet. It is just like a portal that will kind of regulate and streamline the communication, but they are aiming during this year or the next year, I mean, somewhere along the line, the AI will be injected into it as well to make it more efficient. Now, the last thing I'm going to leave you with is, because AI is a very hot topic, and you might hear it a lot in your GP practices, either from multiple companies that can convince you with AI, medical scribe, or ambient AI. There is a framework that was developed to try and give the clinicians a clinical lens about when you look into an AI medical solution, how can you differentiate whether it's a hype or it is a true solution that you can adopt in your practice. So if you see any AI-powered software or solution, think about triage framework. And triage is basically like a very simple 6-question framework. T stands for a true clinical need. Is it really solving a problem that I'm having, or am I buying a clever solution that is looking for a problem? And R is robust evidence. Is it backed up by research, multi-center prospective randomized control studies, or is it only an anonymous kind of single center with retrospective data? And has this AI solution proved to be consistent among all working environments with different machines, different computers, different scanners. And this is the I, the inter-site consistency or not. And the A is for adoption fit. Does it really fit into my current workflow as we stand today, or will it be an extra burden, extra clicks, technical difficulties? And the G is the governance, whether this software is compliant, whether it is has a governance backup behind it, and who carries the responsibility if things go wrong. And the E is the effective decision making. Does this AI solution really change what we are doing? Will it move the needle for us, or is it just like to make us look fancy and progressive? That's it for me. Thank you very much.
Thank you, Shady. I can't stress enough how exciting this work is, really, and I'm really grateful for him making the time today to come and speak to us, as well as David. I think just before I bring on David's point that he wanted to discuss, I think it's maybe a question, Shady, over here from Richard about how innovative his work is. But, you know, he highlights the fact that when you have an atypical patient, you know, that is not a textbook straightforward patient, you know, could the AI triage pathway account for that? I mean, I know me and you trial this this particular model with, say, a question about catheterization in the community, and it sort of came up a bit of a cropper there. But what are your thoughts?
So there is, in the area of AI, there is a very, like a proverb saying, rubbish in, rubbish out. If we program it properly with local guidelines and give it a space to think and to buffer edge cases, then it should accommodate it quite well. If it is down to the programming really and the instructions given to the AI. So ideally, that's why we always have pilot studies, and we have to pilot it in the real world rather than testing it in the labs or just in our heads. So yes, but I definitely this could be accommodated. Yes, indeed.
Thank you for that. And I think certainly this is a very exciting area, not one that we've got the answer to every single query over here, Richard. I don't think they're going to replace urologists or GPs. I think this is going to help maybe with the responsiveness, maybe with the communication language being used between individuals. And I think that's really where the hope is really for this technology to take off, to maybe reduce the burden on our secondary care colleagues, but also for us in primary care to get more responsive answers back for advice and guidance, for referrals, to be told, which pathway should we go down, etc. And you're right, Cyril, the portal at the minute doesn't have a lot of information in it, but we do need to try to address that. We haven't been allowed to touch it yet, but certainly we're hoping, once we've got something concrete that's agreed upon, that's practical, that's workable, that we can take it there and then allow everybody in the county to have access to it. But coming on to David's question, I think David wanted to have a conversation really about pre-agreed investigations for conditions, and I think that's a. Oh, sorry, Shady, did you want to come in at all?
Yes, so sorry, I just spotted in the chat a very interesting question from Julia Railson, saying that would it need to be registered as a medical device? Yes, unfortunately it is, and the governance is very heavy for medical devices, and presumably the authorizing specialist would still be responsible for the decision made. Yes, definitely, and this is called human in the loop. So there will always be a human in the loop to carry the medical legal responsibility. As we said, AI is not replacing clinicians, it is just helping them to be faster and more efficient. But by the end of the day, you as a clinician, it's your responsibility to review what the AI wrote and to authorize it.
And I believe that's the GMC's position as well on this. These are medical devices that need a higher level of scrutiny by the MHRA, but certainly I think the GMC take a view on that as well, that a clinician needs to take responsibility at the bottom line. So coming back to David's comment, because I know time is running a bit short really, about the pre-agreed investigations, David. So, I'll lay a little bit of the ground over here. I think in urology, there is a general feeling that, some basic investigations would help them more efficiently with their triage. And certainly this is what the audits have shown, and would certainly help with the throughput of the patients. But likewise, I think that requires some agreement on our part, and we have to think about how that work may be, resourced and whether we're happy to do it. Now, some of us, like myself, probably are thinking, yeah, some of the investigations would be happy to do. Some of them, I've spoken at length, I think, to David about like ordering investigations where I know, my colleagues working with me, just would not be comfortable interpreting the reports or, not figuring out why we're requesting a test, for example. So they could do it for like a HbA1c and FBC and stuff like that, but maybe for a urogram, they might not be sure what we're looking for. But I want to open it up to David and then the audience really for a few minutes, if we're allowed. David?
Yeah. Thanks, Ammar. I think it was actually brought up by one of your colleagues who basically was saying on the portal there was some documents there that they'd been agreed. So that's why I thought I would. I was trying to stick away from anything slightly controversial today. We're all trying to be on our best behaviour as we're kind of interfacing nicely. But I think the results, the requesting investigations is quite an important topic. And I think you actually mentioned it in your presentation, Ammar, about the smoothness of the one-stop clinics. If I've got a patient on a LUTS pathway with no PSA, I cannot outcome that patient. I will have to bring that patient back, whether it be physically or a virtual clinic. So if we've got some standard basic tests that are done, then it will facilitate a quicker management plan for the patient. So I think it is really important to do that. And I think one of the interesting things looking through your systems, GP systems are so much more advanced than what we're working with in the hospital. And, you showed the facility where you can group several tests together. For LUTS, you need UNEs, MSU, HbA1c, PSA, etc. And then you click the button and all those tests are requested. So I don't necessarily see it as a burden. People may want to see the justification for why you're doing these tests. But I think it's for us as, and this is where the interface group would work really well. What do we perceive are reasonable investigations requests before you send patients in? I think if we can get that kind of standard agreement, then those are the things that would go onto the portal so everyone knows what we've agreed. This work has actually already been done previously with ours and actually was agreed by the commissioners, but it was just that we struggled getting the south of the county to be on board with it. I prefer to take everybody along with the journey rather than implementing things. And again, I thought this is a really good forum to bring it up. Thank you.
So certainly, if people have any comments or thoughts about, whether they'd be happy with sort of a list of sort of pre-agreed investigations for, say, a LUTS pathway, like requesting, I don't know, I think most of us do these things anyway, like an MCNS, HbA1c, FBC, that sort of thing. Would they be happy for that sort of table in a tabulated form to be available on the portal, or would they, would they want, more discussion around that? I think, from my point of view, I'm quite comfortable, I think, probably with some of those investigations, because if they come back, I know what to do with them, I know how to interpret them, and we do that all the time for all our prof work, etc. But I think certainly it would help, I think, with the throughput. And it's a bit like what Shady was saying, if you put rubbish into AI, you get rubbish out. And I think same thing with the machine, the behemoth that is the hospital. It's the referrals that come in, they don't come in a homogeneous fashion, so it's very difficult for them to then navigate into the right place. Now, you could all argue that, yes, it's a their problem, but actually, I think it affects us and the patient. And I think from that point of view, we've got to come up with a solution that's workable for all of us. And I think as clinicians, if we're talking to each other, I think we're much more likely to come up with something that's much more palatable, much more agreeable to all of us. And if we know that the backing is there to support us with delivering those things and supporting us to do that rather than us being done to. So that would be my plea, really, is for people to really come forward. I'm going to put my email in the chat anyway, so please do reach out to me if you've got any thoughts, comments. Am I barking up the wrong tree? Just share with me and tell me where I should go, and then I'll try and take it from there.
Is it right if I butt in? If we just wondered if we could, we could introduce Emily, and so she can describe what her role is, and then we can move on to a slightly more generalized discussion on the interface if people have got the energy to stay on for the last few minutes. So Emily, are you still here?
I'm here.
Still with us?
I'm still here, still with us. Being very excited by lots of things I'm hearing. So I will be very brief. I just wanted to butt in because this seemed like a very good meeting to introduce myself and my role to everybody. So since April last year, I've been hired by 1 day a week for UHN as the Associate Medical Director for the Primary Secondary Care Interface. For the rest of my working life, for those that don't know me, I'm a GP partner based in Corby and Woods End. So I'm spending effectively half a day a week in each of the hospitals, being a resource for various consultant colleagues and exec colleagues to use to get that GP perspective. And as you can tell from what these guys have been doing in their specialties, it's quite a huge piece of work. There's lots of stuff going on that's quite exciting. I really just wanted to share the fact that the role exists, and what I've found out during that is the hospital is very, very keen to work with us and get some of these pathways in place, which is sort of what is being reflected here today. I also wanted to share with you, I think Cathy alluded to a couple of documents that the Interface Board has managed to get through a little while ago now. One is a prescribing agreement across the interface, and the other one is a standards of care agreement across the interface. I've not been able to put them in the chat like I wanted. I've emailed Craig and asked if he can try and share them. But what I have done is drop them into the primary care WhatsApp group just so that people can have sight of them. And like Cathy said, I think the LMC is getting some quick guides put together as well once the wording is done. So that's all I was going to say. I basically wanted to say I exist. UHN is trying to work with us. It's going to be slow progress, but there's lots of exciting things that are coming. And I think probably Ammar and Farouk have had a good few hundred ideas there, that all of which could be beneficial. It's just a matter of working out and progressing some of them. And that's probably replicated across all of the departments. So hello all.
That's brilliant. Thank you, Emily. I'll also just sort of continue with the theme of the things that are going on, just to share who our team are, who are just moving into specialties. So we've now got 2 new consultants working with us at Northampton General. So we've got Ami Shukla and Imogen Norton. We've got Emily Jackson is working with Mrs. Shukla, Sean Lowe working with Dr. Norton, and then we've got Dr. George Bennett, and she's doing mainly working at Kettering, starting off with the new specialities, but also trying to link everybody together a little bit more, so that we are providing some consistency, to trying to link between the 2 hospitals and the different specialities. So just to let you know that that's what we're doing going forward. So we're in our last few minutes, so just if people want to carry on with the chat or ask any more general questions, or carry on asking urology or dermatology questions, then please do. It's a good way to make everybody go quiet, isn't it? David?
Yeah, just a little quick thought. As the numbers of interface GPs increase, I think Ammar's suggestion in terms of setting up a network of GPs who can liaise with each speciality. If we got to that position where we perhaps could start doing that, so some of the questions that we've been hearing this afternoon may be relevant to specific specialities. I mean, some of them are more generic, I appreciate that, but if there are specific examples, then is it good to try and perhaps start that up? And maybe these would be things that we would put on the portal. Just a thought.
I think absolutely, yes. We need to be all joining up and communicating. So create these channels for us to communicate better. So yes, definitely.
I think there's a general, push towards, better relations. I think that's the key thing for me, is that, and I would really like, to get to know the consultants in the hospitals, and, for them to also reach out to us. Chances are Rachel Reeves will make me work till I'm for another 30 years at least. So it's in my own self-preservation mode really for my longevity to make sure that these things are here to make lives a bit easier for us all around really, and to avoid frustration and late finishes to the working day. So I think everybody shouldn't be scared about getting involved. I think you'll find that a lot of the clinicians, who we might think are Marmite, are not that way at all actually when you start sitting down with them in a room, speaking to them face to face. So if anything, please do, join the team or contribute to the team, and any comments or feedback that you can give, because what we want is for people to bridge the gap and to work together to find a pathway that will find a way of working that works for both sides equitably. And sometimes, there's a bit of give and take, and we've got to compromise. So we can't be, stubborn. But I think certainly we need your help to guide us a little bit. And when I've been to say talking to Cathy's Docs and Tots group, for example, about some of the things that we're thinking about in urology, like the pre-referral investigations. That's been well received actually when you give an explanation or when you give an understanding of why they're considering this. So I think most of us are quite happy to work with our colleagues in secondary care in a constructive way. But clearly, we don't want anybody to take the piss, and we don't want anybody to sort of left shift to the nth degree really either. We've got to find a middle ground, but we've got to be in the conversation. We've got to be on the pitch to make a difference. And I think that's why I'd encourage everybody to reach out to any of us and to help us improve pathways. We're not going to be able to solve the IT problems, but certainly we'll try our best to maybe where common sense should be found in the corridors. We'll try to encourage people to think that way.
That's great. Can I use this opportunity to introduce Richard Timms, because his project is very much relevant to this. So Craig, are you able to allow Richard's camera?
Sorry, Richard, could you put your hand up, and then that way I can find you quickly. Thanks. There we go. You've got them now. You can take yourself off mute.
Perfect. So I don't know if everyone can hear me okay?
Yeah, great.
Yeah, perfect. My name is Rich. Just to jump on board this quickly, Cathy reached out to me when I put something on the group, and so I've been working for a bit of a time working with what used to be the fellowship about this exact thing, integrating us as GPs with specialties and wanting that connection, because I had it coming out of training, but I know that a lot of people can't get that interface between there. So the idea was everyone that if someone wanted to be a GP, WR or get some specialists, how can they reach out to people? And that, a long story short, led to creation of a website. Now I can't share it, Craig, either. Share my screen, but I'll create a website called www.gpwer.co.uk, and that will allow people like, I'm not forcing people like David, but David, who has realised the power of communicating with us and allowing GPs to have that time in clinic and that interface. The specialists that be willing to host GPs. There's an easy way to connect up. It's all safe. It's all your GMC is used to confirm you, and it's and you won't get spam or anything like that. So the idea is a GP would go along, they would register, they will be able to search in the area for a specialty, the specialist that might be willing to host them in clinic, and then from there. You could connect up and reach out, and then build a connection and future clinics, and hopefully develop GPWs in the local area of the future, commissioning services and all sorts of things. So I can't show my screen. Oh, I can show my screen. Thank you, Greg. So I hope you can see this quickly. It's the website. I'll share it really quickly. I know everyone wants to go, but this is it. So it's GPWR. I'm based in Northampton. I'm born in Northampton. I came back after many years studying at other places to come back to Northampton. So I want it launched here, but it is nationally at the moment. But I'm concentrating on the people in Northampton and Oxfordshire regions because I'm in Brackley. Now this is it, just to show you very quickly. There's a couple of ways, but you can log in, register, and then search. And this is the main USP. So if I was to do something like minor surgery, we only have a couple of people at the moment. You'll be able to see that where someone is that could post you, and then what you could do is connect with them, essentially contact, and you can check who they are on the GMC register as well. And what we want to try and do is build that up, especially in the Northamptonshire, Oxfordshire, Leicester region and the surrounding areas, and then build that up from there to get more of these kind of things that you've been talking about with Ammar and David and Nafi, I think it was, that, you know, you've seen the connection and build that up essentially. And David just asked, looks good, how do possible specialists? So the specialist register, their details goes on. There's not a way to, there's no shared information. It's just, as you can see, your name will be hosted here. A GP would contact you, and then at that point, they would, you can accept kind of to start that conversation, or you can say, look, I haven't got capacity right now. I appreciate it. You know, I can't really host you right now, or yes, come and see me in clinic. We'll make some arrangements. So I hope that shares it very quickly. And there is a resources page. I've tried to keep up to date with everyone that has a clear process or anything like that. Oh, perfect. Yeah. So I don't know if everyone can see it, but see it there. I'll stop sharing now because I don't want to hijack it too much. I'm sure there's other future opportunities, but yeah, I'm really keen to get this going and having a few more specialists join in. We did have a few technical issues just recently, but I've resolved them now with literally just 2 minutes ago with my technical colleague. And so it's, yeah, everyone should register and be able to use it and hopefully start connecting. That's all it's there for.
That's great. Thank you,
Thank
Richard.
you, Cathy.
I mean, it would be absolutely brilliant, you know, if we can use the contacts we've got to get more consultants, you know, to put themselves out there, and us as GPs, you know, to use those opportunities, and it would all help to help those relationships. If we're sitting together in the same room, it just
Exactly,
helps. So no, that would be great. So yeah,
Thanks
thank you.
Thank you for the opportunity, Cathy. Thank you.
So yeah, any more? We're going to allow you to get away 15 minutes early. So hopefully we've all put to emails and that sort of thing in the chat, so that you should be able to access us if you've got any further questions, or point you to somebody else who will know. So yes, well, thank you, everybody. Any last comments from any of our speakers? If not, thank you so much for joining us, particularly David and Shady. Oh, Tarek, you've got a question. No, was that an accidental hand up?
I think maybe it was, yeah. I think it was a lingering hand, maybe accidentally.
Okay. Well, thank you, everybody, and have a good evening, and hopefully hear from some of you soon.
Thank
Bye
you.
then.
Good afternoon. Bye.